Yes. Okay, guys. So, welcome to this the third session that we have for our IDAHOT campaign this year in the IFMSA. My name is Carlos, and I am your regional assistant for the Americas this year. I am super happy to be here and with you for this third session. So, what we wanted to prepare for this session is being an LGBT advocate and an ally. The idea of the session is to introduce you a little bit more to how to work as a healthcare provider, take into consideration sensibilities and being inclusive with the LGBTQ plus population. And for this, we have a very special guest for you guys. This is Dr. Mohamed Alborgi from Egypt. I am so happy to have you here. Thank you so much for being with us. We are very also like nervous and excited because it is definitely like a goal for us like to include also more like the EMR region within our activities. And I don't know if you want to say hi to.
Hi Carlos, hi everyone. Myself, I am Mohamed Alborgi from Egypt. I am a physician, so for the IDAHO, if my experience with populations, including the LGBT community in my country. Just before I start, I was thinking about what should I say exactly, but I think for that it's Hippocrates law, and I believe in all faculties of medicine, schools of medicine worldwide, we need to oath this oath before having our medical license, and this at least this is what happens in Egypt, and in that we would say that we respect the patient, keep his privacy, and not and treat him as much as we can rather than anything else. So this is, I think, this is the main point in our medical profession. We are here to heal patients. We are here to people are coming for our help, and we are trying to help them. So this is what we should be doing, no matter who, when, and where. And even if it's civil war or someone we hate a lot, we should be treating this patient with dignity and with no bias and with no stigma. Um, and honestly, this has been principle in my medical career. And this is how I see it. The person is coming and it should be appreciated than being looked down upon. During our medical
Okay, guys, so we're having like technical difficulties, which is totally normal. As like unfortunately, we study medicine and not like engineering, like electronic engineering and everything. It's also like super important, like for us to try to maintain everything. Like, okay, so I think Mohammed is back. I don't know if you can.
hello.
Hi, are you hearing me?
Yeah. I don't know what happened, but it seems not from my side. The internet was down, but not from my side.
No,
Or
it,
is
it
it? Was it from my side? I don't know.
it's okay. It's okay. No problem at all. I think we
Okay.
would you like to restart again, like with the introduction?
Me to start again the introduction.
Sure, no problem.
Okay. Okay. So I will do it one more time. I am Mohamed Alborgi. I'm a physician from Egypt. I'm here to talk about my experience with working with the LGBT community in my country. I am here also would like to talk about being a better or a more qualified physician in general. I will start by saying, and it happens everywhere, and at least in my country, before we graduate and we become member of the medical syndicate, we have to repeat or swear the Hippocrates oath that we are going to respect the patients, keep their privacy, and treat them with dignity. And I think many people think that this is something that you do it and just it, but this is an oath, you do it for life. And since that we have to respect the promise or the oath we have done. The things I don't know, but let me put it also to talk about this. We as a medical care professionals, we and anyway as human beings, we sometimes tend to judge people. But when we go and start working in hospitals or clinics or wherever, people are coming us as patients and they trust us and they confide in us. So we should be treating them with dignity, keeping their privacy, and not to judge them. A patient to come and speak about problems that he's having, it's a huge burden and an effort that needs to be appreciated and respected. This helps us in our medical diagnosis, and it also helps us to listen to the patient. Our job is not only to treat, but also to be active listeners and understand. Uh, so if you start judging a person all through the medical history, you might be misdiagnosing him. I also realize that sometimes issues are not treated, but we have to sit and listen. Also, I would like to talk a bit more when we are going through the questions. There is a question that says, how can we be more inclusive as healthcare providers? Okay, well, let me put it this way. Uh, if I'm a healthcare provider, uh, I'm posting on I don't post on my clinic like men only or women only or religious people only or a certain religion or sect or a political party. It's a clinic and it's open for everyone. Let us remember, for example, that according to Geneva Conventions and the United Nations and everything, if there is a war zone or a civil right, you find medical professionals and healthcare providers going into the war zone, treating everyone from both sides and moving out. And if we go back to our medical practice, it's the same. A person coming to the hospital, he's not coming to get acquainted with me or to be friendly or someone to speak to. He's coming here to be treated from something his own. And if the synonymous word for the word physician is a healer, I know it's some people don't agree with that, but it's a healer, and we're here to treat and cure the person before anything else. So we can't be just saying like we are allowing a certain group of people to come, be treated, and that's it. But of course, I would like to talk about violations that happen over there. Many patients would come to our medical practice, and unfortunately some of our colleagues and medical professionals would be judging them, and I don't know how to say it, but there could be misdiagnosed, they could be given the wrong treatment, treated in a disrespectful way. uh, Maybe with time and in the future more and more guidelines would be done, and this is why there is something called medical ethics, and this is a new branch emerging in many universities worldwide. But let me put it this way. The moment that you put on a scrub or a lab coat, uh, this means that all of your beliefs, all of your principles, you are putting it behind, and the only thing that you believe in and principle is treating the patient in front of you, no matter what, no matter where, no matter when. So this is what I wanted to say. Like, if you disagree, you have to make it loud and clear, no matter where, and at that point at least you will stop the patient and keep the burden of revealing himself and going to you. And I think this is completely wrong because we can't do that. um, Carlos, are you hearing me? Carlos, are
Yes,
you hearing
yes,
me? So
I'm
I
here.
think this was the first. No, I'm sorry. I'm just was worried that I'm just going on and no one is hearing back. But so this was my first question. This was one of the questions that we mentioned. Yeah, and I'm sorry because of the internet breaking up. I forgot to say, like, I'm really grateful for this opportunity. It's late, but I have to say it, and
It's
I am
totally
happy
fine.
to be with you, and you are going to be my colleagues in the future, and I wish you all the best of luck in your medical studies. So the questions about what are the difficulties found in your country to advocate for LGBT rights?
Yes, just let
Uh,
me just like do an introduction to that question. We were actually thinking about like talking about what are the actual social cultural barriers that you can find, for example, not only in Egypt, but what are those like what prevents us as healthcare providers like to go a step further, in understanding the LGBT population and everything.
okay, thank you. This is a very good question. Um, well, we are not living in utopia. We're living in on Earth. On Earth, there is over 170 countries. Each country there is different traditions, different cultures, many religions, many affiliations, and so on. So when we grow up, our parents raise us, the community raise us. We are being raised in the school, and we are being taught what to do and what not to do. And many of the things which are taboo topics, or many of the things which we frown upon in our is things that we haven't learned about as children. We haven't been raised, or things that we have been always told this is wrong, you can't be doing this. So this affects us, and no matter what you try to be non-judgmental, non-biased, professional, this affects us. Whether with empathy, or whether with anger, or whether with what. Like, for example, a woman who's delivering and her baby, it was a stillbirth, who dies while being delivered. You can't be not saying like, okay, it happens. Like, you feel bad for her. Or a patient that who is diabetic, or a person, or telling a patient that you're having cancer, or you're HIV positive for the first time. All of this affect us, even through experience and through time. We get to be, I don't know how to handle it better. However, the problem is that we need to keep in mind that we are not religious leaders. We are not giving advices from life. We are not taking the morals and all the good things we took from our moms and dads. We are here to work and heal patients. So I think this is when I would say, like, we have to censor a bit what kind of information we are telling to the patient, and also we have to learn to treat them in a proper way. Um, I would say, like, this just came into my mind, and I was talking to some of my colleagues. Even if we have problems with someone, it's like a poker game. We have to show a poker face. I'm not asking everyone to be very sympathetic or friendly with everything that he sees and meets in his medical practice, but at least, like, be professional, and this is good for you because if you start judging people, you will start judging one or the second or another. Here we're talking about gender identity and sexual orientation, but trust me, it will go into deeper than this. You will be starting judging people or being biased with people from different political parties, from different nationalities, from ethnic groups, from different races, and this is so wrong. I mean, maybe in my country now we don't have a proper legal system that would punish and would punish or judge these unprofessional actions, but advanced countries and developed countries it is, and I think this is something that is going to be very soon universal worldwide. And I was answering the other questions. If I have a problem with a patient, we need to clarify that with the patient himself and just refer him to another one who's more professional. I hope I have answered your question, Carlos.
Mhm. Yes, yes, very, very well, actually. I wanted like to go like then a level like deeper into like knowing about yourself. Like, what were like these barriers in your medical practice? Like, what did they represent for you? You know, like how were you able to like surpass them? Did you like rely on friends? You know, what would you like to say like to medical students to pursue with this?
Um, I don't know how to put it, but um, I don't know how it started, to be honest, but I'm looking it as that. As a kid, I had this fear of doctors, and even while growing up, I had for one time a problem. I made a small accident, and this is the first time to answer it, so I'm just bringing up ideas. So I remember like I had a cut wound, and I and I needed to be stitched up and taking up a couple of nails. So I remember that the doctor looked at me and he talked to his nurse in English and he said, "This is a very naughty boy and he's bringing trouble to his family." Um, I looked at him. I was a little bit uh, embarrassed about what he said, and I replied back in. He thought I think he thought that I don't speak English, and thought I didn't mean this to happen. This was an accident. So this judgment was, it was right in my face. And at that young age, I had this kind of like feeling like I hate doctors and I hate how they judge me and how they treat me. And yes, I remember also like when he was doing it, I was crying in pain and he didn't even bother and was just doing what he was doing. So, and then when I was growing up and I said I would like to be a doctor, maybe I'm not sure. I'm not just being idealistic, but maybe I thought I wouldn't be that person. But also, I am very grateful for my upbringing that I had contact with people from different backgrounds, different cultures, and this made me open to new stuff and realizing that the world is not only revolving around me, my culture, my background, my religion. There is more and more things coming up and I have to be always eager to know more. And the more I know, the more I'm going to become a better human being and a wiser human being. So I think this is what's up. And I remember also like in my medical school, it's the Faculty of Medicine, University of Alexandria. There used to be a few, not many unfortunately, but a few physicians that I looked up on them that who kept on repeating that like the patient when they come to a clinic or a hospital, they trust us and they trust us with the most valuable thing in their life, which is their bodies. And we have to be responsible and we have to be what's the right word, we have to be responsible and take care of that and give them back what they have and even in a better shape. And we should never keep on talking but many of my professors were talking about the socioeconomic background and the educational level of patients. But I think I also, when working with different groups, I started to realize like, no, this doesn't apply only to backgrounds or education. It has to be done with everyone. And as a physician, and let me put it, we keep on saying like we have a high IQ, we have a high educational level, so we need also to learn to have a high social IQ and to learn with different people in their own way, not in our way. And also this is something that when we are discussing an illness or a problem with a patient, we have to understand and realize at what level that we are talking, and we need to have the medical terms when we can, but we also need to explain it in a very basic form. So this would also bring us back that we have to go to the same level of understanding of the patient and take him up to our level. And this is actually, yeah, and this would come with practice and you would see it, but it also like have to do, what we have to do is like think about what the patient wants before anything else.
Awesome. I think it's very nice like to speak also in terms of not only what is our role, but why did we chose as well like to be like physicians, and like what is our pathway, like what a road has for us, you know. It of course has like many obstacles and many debates, like internal debates, and I'm sure like for many students like watching this, it may be like something they see as impossible because of the barriers, but because of the social cultural barriers. But it's really nice like to hear your story in terms of
I'm
surpassing
really not
those and
sure.
actually
Like when you just
embracing
asked me,
this as a new road, like as a new, let's say, way of living, and that you're not fleeing, you're not like evading what you wanted to do as a doctor because you're doing something different. About you, like she told us a lot about your work with HIV, you know, and your work with the LGBT population as well in this scenario specifically. So I wanted to know if you could like speak for us a little bit more about this this experience that you have, like what is also like the combined stigma that we can have, being first a person living with HIV and as well being part of the LGBT population. How do you see this in Egypt? How has your experience? What has your experience taught you?
hmm, uh, okay, let me put it in this way. My first contact happened as a medical student. There, I had my own prejudice and judgments, and then this journalist who came who wanted to make an interview with medical students and asked me about some questions about HIV and people living with HIV in Egypt. And of course, yes, I remembered. And of course, like um, I used what my social background rather than my medical background. I was ashamed to tell her that in my medical background I don't know much, but I kept on saying about my social background and everything about it. Unfortunately, later on, I decided, okay, I need to go back and check what I said is true or not from a medical perspective. And I found out that there's a lot of things that I have said is not true. And it's wrong. Like for example, here in Egypt, it's being thought that people living with HIV are being locked up in a quarantine, but this wasn't true. In Egypt, it hasn't happened since the 90s, and and at that moment, I remember this was my first interest to deal with HIV. And when talking about HIV, we talk about key populations, which are female sex workers, MSM, men who have sex with other men, transgender women, IDUs, intravenous drug users, and this is when I was trying to work or find my path. I wasn't focused only about, maybe I'm having this gift, but I wasn't focused only about dealing with community awareness, but I'm doing it right now. But at that time, uh, I didn't think about, I don't know, I just let myself open to everything, and to see what will happen. So yes, so now when I was working with populations like and yes, and then I started to go to the root of MSM and transgender women, or and dealing and being more in contact with the LGBT community, and I think what I have seen is at the beginning it was mistrust, and with mistrust comes questions about revealing and exposing things. And here it was people were not sure why I'm helping, and if I'm helping correctly or not. And they have been always challenging and questioning my belief, um, and why I'm doing this. what I wanted always to prove that I'm trying to help people, and we are all human beings, we're all different societies and communities, we are all the same, and we are here to help. I started working with awareness and awareness within harm reduction and within key population, which is MSM. And this is when I started to realize that it's not only about medical problems. They suffer a lot of social problems as well, and there is a lot of violations in the medical practice that they can't reveal their seropositivity, their HIV status with physicians, and at this they could be prescribed not the exact or the proper medication. They don't reveal what risk they are at, and if I wanted to do it this way, even for us as physicians, if a patient does not feel comfortable with a patient, with a physician, I mean, um, he is not going to come back. And this would mean low compliance. And low compliance would mean that the patient will not be treated properly. And I'm sorry, and also we have to admit, if a patient is not treated properly, we're not good physicians. And as I said, our duty, and I'm repeating it, our duty is to treat patients, not to judge them or to give them advice. Uh, So, I mean, as a medical student working, as many of you are working in many fields with sexual and reproductive health and rights, HIV, female genital mutilation, sexual and bodily rights, and so on. So all of these branches that I have been working with as well, and I was branching out, receiving more and more. And I think this has prepared me as a medical, when I was starting my medical profession and my career, that I would say I have seen a lot of things, and I'm not anymore surprised. And I learned how to not to be judge people, but to look into the social aspect and realize things like why they don't go to a physician, why they don't seek medical help, how can the medical and the healthcare providers help people more, and so on. And what I wanted to say, like, I'm not sure if you can direct me or not, Carlos, but there is many minorities around us in many countries in the world, and in Egypt, like the LGBT community, they are invisible minority. These minorities, like you can't identify an LGBT person walking down the street or coming into the clinic between other patients. He come and he has the burden of revealing himself to you. So trust that I face and I experience in the beginning of my work with communities and as an outreach worker, that they mistrust a physician, and we have to assure them that they should trust us and our confidentiality. This happens in Egypt, as I said, and it's everywhere. I mean, it's the West, the East, in Europe, everywhere. Even if it's in developed countries or in Europe, that there is more and more acceptance to homosexuality and trans community. But there's still, we go back to what we have been raised, we have seen as kids, what we learned in school, what we have learned in our religious organizations and affiliations, and so on. So we come and judge this group of people along with many others. Um, and this is why these communities are in secret. Also in Egypt, I would say, if I want to say, like, almost all Egyptians are either Muslim or Christians. We have different religious minorities like Baha'ism, Judaism, Shiite Muslims, and so on. And all of our medical religious organizations, they forbid and they look down upon homosexuality and trans people, and see them as something immoral and something that needs to be punished severely, and so on. And last not least, and this is also very important, that in Egypt we still have laws that criminalize homosexuality. And of course, when you're going to a public institution and it's not in private, you come and you face the question of will this doctor come and report me to the police or not if I started to talk, because here I'm confessing about stuff. And this is also part of the physician patient protocols and agreements and ethics, that no, we should assure the patients that what is being said in the medical practice or the healthcare organization and institution doesn't go beyond the walls of that. Except if this person is dangerous for other people. And some people, and I have these discussions with my colleagues, they keep on saying, but this patient is a danger to himself and we should be helping him. No, we shouldn't. We should be helping him if he's going to kill himself, which is like, I would say, suicide. But if he's having a risky behavior or a risky lifestyle, I mean, this is for him. We might be saying it or hinting it in a very sublime and in a very non-biased way, but rather than that, we don't have any right to be judging or any right to say or to do what this patient is doing.
Okay, so I think it's also like very interesting to also know that discussion of minorities. I think, for example, here in my reality in Brazil, we have a lot of them that clash, that combine, at the time of seeking healthcare, and that is also like a cumulative, let's say, factor that does, let's say, prevent people from getting universal access to healthcare, which is something that, of course, like we fight against, as doctors. Um, there are, just like for people to know, there's still a lot of countries actually, I don't know the updated number. Actually, Jenna talked about it yesterday, in her LGBT history webinar. So like, to check all the facts, see yesterday's webinar, check out yesterday's webinar. But now I wanted to ask you, what do you think are those health needs, health needs that the LGBT population is lacking? And do you have any strategies to, have you thought about any strategies to get there, like to have health access for them, or anything like that?
I just want to point out that, thank you, Carlos, for directing me. I just want to point out, for example, people living with HIV. The MENA region, the Middle East and North Africa, is the only region worldwide that there is a growing number of cases of HIV day by day. And but it's also because of the stigma that HIV is being transmitted behavior one, and this is a curse from God or a punishment from God, and it's the abomination of humanity, and so on, so on, so. But in reality, like if I would say, like a country like in Egypt, it was to the UNAIDS office and the reports from the Ministry of Health. People, how can I put it? Yes. We are trying to go back in epidemiology and knowing the risk and trying to go back from the roots of the problem, that people who are living with HIV has contracted the disease through homosexual behavior were only 30%. So we have forgot all about the 70% of the other people about the homosexual behavior, and this is completely wrong. And this is why what I keep on repeating, that if we are biased, we keep on forgetting a lot of stuff in the medical history while listening it to the patient. We keep on judging this patient that he does and he doesn't do this, and this is how he lives, and we forget about the important stuff, and we miss it. The medical coverage for people living with HIV medication in Egypt is less than 30%, which is very low, which means that over 70% do not seek medical help. And of course, these people are not individuals. These people are part of families. Families are part of communities. Communities are part of a bigger society. If I would say the needs for the LGBT that are being lacking in my country, I don't know how to put it, but there is many things that are being lacking worldwide. We don't have proper medical researches for these communities. We don't have in our curriculums and in our studies any thoughts about that. In Egypt, for example, the mention of LGBT behavior is always being linked with HIV. So when we're learning about HIV, we learn about this practice. Anal intercourse is being related to this. In spite, anal intercourse it could be also a heterosexual practice. but also it is being specifically mentioned and like elaborated in not that much, but elaborated in psychiatry, in our curriculum psychiatry as a mental illness. In spite of that we are celebrating today, why we are celebrating Idaho, it's because the WHO has removed um, homosexuality as a mental illness. We still learn that in our medical books in Egypt, and I think it's also like if I'm not only judging Egypt and the Orient, but I'm also looking it as abroad. Many of all of our textbooks comes from abroad, and even if it's being mentioned that it's not a mental illness in many of the textbooks, or it's a diversity in the sexual orientation, it still exists in books of psychiatry and psychology. And this is my own personal opinion. We need not to justify that. If you are going to celebrate truly this day and knowing why we are celebrating, because homosexuality is not a mental illness. And there is also, if you also talk about the LGBT population, and we have to be inclusive, there is also the trans community, identity disorder. These are the things that we have to celebrate,
Okay, guys, so we are facing apparently like technical difficulties as well. Like again, I'm sorry for the inconveniences. We were like previously, I just wanted like to take then this time like to bring up a little bit more of like the discussion we were having now. We were now speaking about like what is that the LGBTQ plus population needs like to get access to healthcare. And I think one of the main points like raised up here was the necessity of research, you know, and specifically like comprehensive research for this population, which is a lot like it may seem kind of easy, let's say like that, but it's actually not because first like beforehand you actually have the opportunity of doing research for the LGBT like with LGBT population patients like by let's say in not inertia but by ethical principles you need to accept there has to be a safe environment and let's say professional serious environment for these people like to actually disclose and do everything like okay, you know, like do everything how do I say this like coherently with what you want to research about. And this is a main barrier that we have as medical students because when we go and advocate like, for our medical schools, for the lawmakers in our countries, and we don't have that scientific fact that by discussing this is important. Speaking about and advocating for the LGBT population is important. We don't have like the fact of having like the research paper that says that 60% of people are suffering of, let's say, I don't know, diseases. So I think Dr. Mohammed is back. Are you able to hear me? Okay. Also, we are actually Vivian here is working a lot, like in all the questions that you guys are making in our Q&A in Google Hangouts and also in this YouTube video link. So we will see if Dr. Mohammed is able to reconnect. If not, we'll let him know about your questions and we'll try to like get the answers as soon as possible. I also would like to raise another point in terms of the medical needs as well. Um, we don't like one of the main things that people believe like is that necessarily we need a specific facility for the LGBT population to be in, and this is a great debate right now because actually if we are considering the LGBT population to be just as anybody else and fight for the same rights as a other population, in theory, like within a public health system, this would translate in not necessarily having the necessity of creating new institutes for people. But why is like they're there for a reason. Like it's not like I'm going against the institutes or anything. It's just that it shows actually the like lack of capacity that we've had like in as legal makers, you know, as lawmakers, and as the discussions in our Congress and anything like that, that actually leads us to say that we actually need a specific space for the LGBT population to feel safe. And this is also kind of like part of the debate we wanted to rise with this space. Because of we are having this such specialized, you know, matter in terms of having healthcare for the LGBT population, and we're never aiming at opening that to actually have a public health inclusive system, then we are actually advocating like counterwards, you know, in terms of having the enclosed space, like the separation, the physical separation of people. And that has happened in history, not only with the LGBTQ population, but as well with the colored population, with Afro-Americans in the United States. Like, I don't know if you remember Rosa Parks ringing the bell. But all of these examples are like examples of that types of segregation that may happen. So it's not like it's wrong having like LGBT like centers and everything, but there is a need of consciousness of fighting for a public health system that's inclusive. So we don't need to waste more money, like a lot of money, in terms of making the specific space, in terms of the high point tech that we need in a specific place, and also making a better usage, let's say, of a public health system. This actually rises access to healthcare. Okay, so one of the difficulties that we have here in Brazil, for example, towards the LGBT population specifically, is not necessarily within its law projects, because we do have lots of social movements that advocate pretty well for the LGBT population, but it is two factors. The first, I think, is that one of overlaid stigma that I discussed a little bit later. So for those of you who don't know what overlaid stigma is actually taking those other cultural factors that make you different or make you a social minority, and you mix them up in a bowl. And that will actually have an added social determination. So if, for example, in my case, I am Latino and I am gay as well, and I come like from an indigenous, like, let's say, background. So this divergent thing is not only in my health and medical treatment, but also in my access to it. As well as, for example, people that Afro-descendant people and that are members of the LGBT community are more propense here in Brazil to suffer more obstetric violences, to suffer more malpractice, let's say, from doctors, than LGBT population that, for example, has no other type of, let's say, social minority characteristics, like, for example, skin color or indigenous tribes or anything like this. So this is very interesting to analyze because it's not only advocating, when we are advocating for the LGBTQ plus population, we are not only advocating for sexuality and gender identity. We have to take into consideration all of those different that probably will not let us like get into the health system and get the proper healthcare we need. Um, One of the last point I wanted to discuss was something that Dr. Mohammed also mentioned, and it's the term MSM. We MSM is actually a medical term that's to it's called men who have sex with men. I like to say that have sex with people that have penises, and because it includes not only cisgender men, it also includes transgender women. This is why it's a little bit polemic, and it's in constant discussion right now. But right now, for those of you who didn't know, because Dr. Mohammed was mentioning it, for those of you who didn't know, MSM is sex with men, and it is a medical term we use right now to parts of the outcome, especially where you HIV.
I am back. I'm sorry. This is my fault. My bad connection.
We're just going to wait 1 minute for him to join.
I am back already. Hello? Hello?
Hello. Sorry.
Hello?
I think this time it's Carlos who is stuck with a bad internet right now. But so Carlos, are you back?
Yeah, I am.
Okay. So we can proceed.
Carlos,
okay, I don't know. I got stuck. I don't know which part I got stuck. I was explaining MSM. Did you guys cut? Viv?
You were explaining what?
Yeah, Carlos, we got most of the explanation, and now we have
Okay.
Dr. Mohammed back. We can proceed with the questions and interviews.
Okay, so Dr. Mohammed, can you hear us? Can you hear me?
Yes, I hear you clearly. I hear you clearly. Carlos.
Okay, perfect. So we can move on then. Thank you so much for waiting on us. So, okay, so I think you were answering that you believe the LGBT population lacks. I something else to the past answer, if you want to continue.
Yes. Well, the LGBT community or the LGBT population is part of the general population, and I am not an LGBT physician. Such a specialty does not exist. I'm an internal medicine, and I'm focused on issues, diseases, and problems related to internal medicine, and this is where I work in. Sometimes from the community, since I'm not that, I'm providing a stigma-free, non-biased, non-judgmental service. They come with other medical problems. I think this is at one point, yeah, it makes me realize that I'm a better physician, but in the same time, it realizes that there is some other problems and some other physicians who should be doing this job rather than me, and they are not. If we are talking more and more about the needs of the LGBT community, yes, maybe they're sexual than the rest of the population, so they are at risk of more diseases, sexually transmitted, There is because it has been proven medically worldwide that people, the LGBT or sexual and gender minorities, they are suffering from health, psychological, and psychiatric problems because of the stigma and the pressure that is being on them. Again, plastic surgeons, I would say, dermatologists, even internal medicine endocrinologists for women and trans women and men doing hormonal replacement therapy. All of these need to exist, and these are the main concerns. Are having the knowledge and experience with working with people living with HIV and knowing when to change the medication and when not to. This is also one of the questions that I believe it's there. Maybe now, I'm not sure. I am not in not well updated with that, but I think now in the United States there is the rest of the world, and the rest of the world, and I would say this: you can't be focused on one thing. We have already our specialties, for example, surgery, internal medicine, ophthalmology, ENT, gynecology, and obstetrics, and so on. So we need to realize that these are part of the population. Some people say they are 1%, some people say they are 10%. Is that from every 10 people going to come back, look through, and the most, it's nothing that, but it's time for you to see something from a medical point. You can ask the patient to come later and so on, and you can discuss that and consult seniors and so on. Maybe they have seen another case, but I mean, if there is something like everyone, all human beings suffer from the same diseases, same problems. Maybe some are at more risk than others, but that's it. Even some races are more at risk than others in certain diseases and so on. So there is not some kind of a package or some kind of a need very specific to these communities.
Thank you so much for your response. Okay, so I think we have some questions for you, Dr. Mohammed, from viewers at home, and Vivian is going to read them for you if you are willing to answer them.
Yes. So I will be presenting the questions.
No, I mean the line was breaking up. I didn't hear you.
Oh, that we have some questions like from viewers at home, and Vivian is going to like address them to.
Okay. Dr. Mohammed, can you hear me? Okay. I think due to internet connection problems, we've lost connection to Dr. Mohammed again. So, regarding the questions that we already have, we have some wonderful questions that we will post to the YouTube link and to Dr. Mohammed for him to answer later, and just because that he cannot do it right now. But I assure you that we will pass along all the questions and they will be answered in the YouTube link. So thank you very much everyone for joining us today. We do apologize for the connection problems, but we hope that you've enjoyed the webinar nonetheless. Thank you very much. And this, oh, do we have Dr. Mohamed back?
I'm back.
Oh, okay. Carlos, do we proceed with the questions then?
Yeah, I think as long as the internet allows us, it would be amazing.
Okay. Okay. So I'll present the first question. This is a question from Canada. Thank you for the work that you do and for sharing your story with us. Being a country where homosexuality is illegal, how would you describe the safety of physicians and clinics that are known to work with LGBTQ plus people and populations?
Well, it's either this way. Um no one can legally what's the right word? Sue me. I mean, there is nothing illegal about being a physician treating an LGBT person. However, since I'm working in a hospital and this hospital has over 100 healthcare provider or less or more, but this unofficial criticism that's going on, I could risk losing my job at some points. Yes, it's not an easy thing to do it, and because again, if you are working with an invisible minority, and or like they are already in society, and then you are more and more experiencing, you're the only physician experiencing such cases, which would say that this is kind of weird. Like my colleagues keep on like saying, like, how come they only come to you and don't come to the rest of us? Yes, I have experienced a couple of times I was asked of not bringing or not accepting such patients in a hospital. Yes, it has happened, but from a legal, like no one, I mean, I don't think that I am at all in any risk of being arrested for in that case. At least, I mean, yeah, my country, there is nothing properly a statement saying that you can't treat or you can't an LGBT person. Like this is completely bizarre. But yes, I might be suffering problems, but not from a legal way. And yes, homosexuality is being criminalized in Egypt.
Okay, thank you very much, Dr. Mohammed, for your wonderful answers. Because of technical issues, we are now running a little late. I would I would like to take this time to thank Dr. Mohammed for joining us and for your wonderful story and your answers to all the questions. But for the rest of the questions, because unfortunately we do not have more time for them right now, we will, like I said, um, pass them on to Dr. Mohammed afterwards, and the questions will be answered in the YouTube link. So thank you very much, Dr. Mohammed, again, and thank you everyone for joining us at today's webinar.
Thank you all
And
for listening. For giving me this opportunity. Thank you, and I wish all the luck for all of you medical colleagues and paramedical colleagues as well.
okay, thank you
Thank you
very
so
much.
much, Doctor.
Thank you.